Well, I'm really excited to be here. These conferences are very, very interesting to me. I love learning what everyone else from all of the other domains are working on. I will say then speaking at them is always intimidating because I know next to nothing about these other areas. And I try to keep up on the research, but I only really understand about half of what I read from them. But I think that's sort of the point of these conferences, which is I'm supposed to only know my area, and we come together to try to do better together. And so that's really what I want to talk about, which is collaborative care. And one of the models out there, and I don't really know enough about it to critique one model from another, but I just list the medical home model as an example of efforts that are being put forth to think through how are we getting better about collaborating? How are we getting better? Are we getting better about integrating all of the different specialties that each has a different piece towards helping achieve better outcomes? So I just want to talk through two sides of the same coin, which is, from my perspective on the behavior analysis. So how do we use ABA to improve maybe compliance or outcomes with the medical procedures? And then the other side of the coin, which is how do all of these other medical procedures and treatments help improve outcomes in ABA? So as you've already heard, and you're going to hear again, I'm sure, in much more detail and precision, autism has a much higher level of comorbid medical problems. A quick lit search really shows these are the most commonly occurring ones. I don't need to get into them, but yes, we know GI issues are highly common. Seizure disorders, sleep problems are also very significant. And when we approach trying to understand what is going on, we may just see the behavior. But as medical professionals are trying to understand it, the standard assessment practices, they need to be adapted. They can't just be asking how they're doing, right? When somebody is minimally verbal or nonverbal, they can't just say, hey, I hurt here, this is how it's been, and this is how it's been going. Oftentimes, a lot of the signs you're going to see have really, they're just not intuitively related to the actual underlying cause. So for instance, symptoms of GI problems may include self-injury, sleep problems, laying over furniture with weird posturing, frequent throat clearing and chewing on clothes. So these are just examples of the behavior that we would see, the behavior that the diagnosticians would look at. And we could jump to some conclusions. Oh, self-injury is going to be serving sort of a function, and just try to approach it behaviorally and miss the boat completely on what's actually driving and causing that. So as we talk about challenging behaviors and think through these from a behavioral perspective, I tend to think through what in the environment could be controlling this? Is there something in the environment controlling this? And think through things such, is this socially mediated or not? Is this driven by attention, by escape, something like that? Or is this maybe a symptom of an underlying medical condition? Because they really will often appear in the same form. The way that we approach it within ABA is to try to understand what is the function of that behavior. And so we have a lot of procedures that would get at function. Trying to understand, though, why behavior occurs, from just a very reductionist view, behaviors occur because one of three reasons. One, the person gets access to something good. We call that positive reinforcement. The person gets away from something bad. We call that negative reinforcement. Or the person has something bad happen from doing or not doing the behavior, and that would be considered punishment. So the problem with punishment is, while it can be effective at reducing behavior, it tends to stop working as soon as the punisher is no longer present. It goes back to the other way. So that's why it's not a first line approach to reducing these behaviors. So when we think through function of behavior, it's the standard, 4 types of functions that we see in the research, which is an attention function. And attention isn't always just positive attention. Oftentimes attention is getting reprimanded or scolded. Tangible, so that's just getting access to something physical, the toy you wanted, or the food that you really liked, or getting out from having to do something that you don't really want to do. So when I was a kid, I had a really hard time learning, and I would often just throw a major fit and throwing books across the room and all that. And even though my mom still made me pick up the book eventually, that behavior was getting reinforced because I was delaying reading that book for 30 minutes as I was flipping out. And then the last one here to talk over would be automatic. And so automatic is often those things that are, instead of being mediated by the external environment, I phrase it more as being mediated by the internal environment. And so those are typically the things that are self-stimulatory in nature, things that you do because they feel good, or things that you do because they make you feel a little bit better. So an example of something like that, the weird posturing, the leaning on furniture with GI problems, is that pressure on the abdomen can reduce the pain or the discomfort just a little bit. And if that's the case, then they're going to be more likely to do it in the future, and then we will shape up that type of behavior. So I'm not going to go into all of the ins and outs of experimental functional analyses, but there's a very precise step-by-step way that we go about trying to understand the function, and it's the same kind of things. But this produces a graph that looks something like this. And in it, we're looking across the different sessions, and we're trying to understand, like, when we only reinforce one way, so we only give social attention, or every time they do the behavior, we let them get out of the demand that we were putting on them. Or every time they do the behavior, we give them the object that they were asking for. And then we look and we graph like this and say, is there one condition where we see a much higher rate than in other conditions? And this is actually not a great example for me to have used because it's not a real differentiated one. It just shows attention and demand as being high and toy play being low. Toy play is like, you don't put any demands, you give them the toys they want, whatever they want to do, and you just let them be. Now if you see toy play really high, and these other ones are high, and so it's high in all these conditions, chances are there's like an automatic function going on, that there may be something underlying that's medical that's actually driving those behaviors. Now, that's not to say that, if it's not an automatic function, that it's not medical in its nature, because if I have a headache, I am going to be a little bit more irritable, and thus something that typically maybe I'll be a little more prone to snapping at a coworker. I'll call that verbal aggression for here. So I may be more prone to engage in verbal aggression because I've got a headache, and the function would be demand, right? Like I don't want to talk to you right now, go away. So it's an escape function. But what's actually driving that behavior would still be that I'm in pain, that I have a headache. So it doesn't have to be just an automatic function to have a strong medical basis to it. Okay, for the sake of time, we'll skip that. Let me move on to talking about how can we use EVA to facilitate the medical treatments. There's quite a bit actually that's been published on this over the years. I just picked these ones because I like the way Anthony Kubo's lab approached them. And so I'll talk through increased compliance with a physical exam, with an oral assessment, doing a visual screening, and then another group that did wearing medical devices. And then I'll talk through a study that we published a number of years ago on getting compliance with taking liquid medications. So what we have here is, I just took one of the graphs out of this study. There's a whole bunch more if you are interested in it. The references at the bottom, there's all the procedures and everything are in all of these publications. What they really did though is they start with just doing a parent questionnaire, try to get to understand the patient, what's going on, some of the background and the history there. And then doing a preference assessment. If you're going to use reinforcement to shape behavior, you gotta first know what's actually reinforcing. And that's what the preference assessment is for. And then we do baseline, just right out of the gate. Where are they at? How are they doing with it? And then there's the active ingredients, I would say, are really the exposure and then the training. And like everything in ABA, we take a complex sequence and we break it down into very small steps, like at the very small basis, and we build from one at a time until we get to that terminal goal of the entire behavior, the entire sequence being able to be done. And then you go through stimulus fading, and then you generalize it to the actual environment where it needs to occur. So they did all this training in more of a lab environment, and then they generalized to the doctor's office. So what they did here is they just targeted, I believe, it's really small on my screen, so I believe that's compliance with the nose procedure part of the physical exam. And you can see they, as they moved into the training phase, they got compliance with the first step, and then they increased it up to the next step, and so on and so forth until they got the entire sequence of compliance with the nose examination complete. And then they moved down to the lung component, and then they trained that up. And that's not just, tolerating it, but that's actually participating, taking the deep breath when you're told to, and doing all those things. And then the last was compliance with the mouth part of the examination. These graphs and slides, I show them less to really say, here's the one technique to follow, but more that there's a ton of examples for how we can leverage ABA to be helping with these other procedures. Here's one example of getting compliance with an oral assessment. So taking a child to the dentist, my two kids, we adopted them, they're neurotypical, but they still really hate going to the dentist, and it's really hard to get them through that process. And so I kind of laughed when I saw the second phase here, which is chair, because my oldest, he hates getting in the dentist chair, and as he thinks he's going to fall out, and there's a lot of anxiety about it. So I need to use this when I get home. But anyways, they did the same process here. Parent interviews, background information, and then figuring out what they will actually be willing to work for, what's the reinforcers that matter, then breaking it into the different steps, and then building off of one after another until you get to that terminal goal. Now here's compliance with the vision screening. A bit more complicated, but again, they follow the same procedures here, doing the preface assessment, that baseline testing, the training, stimulus fading, and then generalizing to the actual environment where you need the behavior to be able to happen. And so this one also very effective without a ton of work on it. Now this is one, I believe it got published online just about a week or so ago. I was excited to find it because what they did in the previous studies, there's a component to it which is blocking. So if they're going to try to run away, you need to block that from occurring, or block the behavior that you don't want to see. But they didn't do that in this one. They, just by doing a differential reinforcement, so that's reinforcing other behaviors. So for instance, in this example, they're trying to get compliance with tolerating a heart monitor. And so just by identifying other reinforcers, they were able to shape it up. So right here at the top, they named these kids Leo and Adam. So in Leo's graph, you see 60 to 80% removal of the heart monitor during baseline, and 0 to 20% compliance with actually allowing it to be on there and allowing it to be able to do the test. As soon as they move into the treatment phase, you see an immediate reversal of those two lines. You see that the compliance goes way up. And it's variable at first, it's not just a silver bullet, but they, within pretty short order, get it to 3 sessions in a row at 100% compliance. And the removal of the devices down at nothing. Now Adam, he didn't, it didn't flip as quickly. Much longer road for him with the training, but it also ended up at the same terminal point with complete compliance with the procedure and not removing the device at all. So then, talk through this case real quick and then move on to the other topics. But this was a 3-year-old boy that he frequently got ear infections, and in between those ear infections, he was sick a lot. And so he was frequently on lots of other medications, and he hated them. And so he would run away. And it got to the point that he wouldn't take anything, putting it in his milk or his juice, he could tell the taste was different, something was off, and so he would then refuse to have that. And so it got to the point where the only way they could get him to take his medication was via suppository, and that required restraint. And so his mother came to our group. I wasn't a part of this project, but it came to our group and asked for some help. And so what we did is we took that whole process of saying, well, what do you have to do to get him to take the syringe, and squirt it in his mouth with the medicine in it, and broke it into a very, very small step-by-step protocol to get to that point. And so, for example, at the start, if he would just see the syringe, he would run away to his room and hide. And so the first step in training this was just to put the syringe on the table in the same room with him and have him not run away. And then the next step was, well, to put water in it and let it sit there without him running away and hiding. To the point then they started putting in food coloring, and so it would start to match the pink color that the medicine was coming in. The terminal point here, though, by the end of the study, his mom was giving him the medicine on her own without any protesting from him as well. And so, there's a number of studies that have shown compliance with taking medication. There's a lot that we can do to make that process go a lot faster and smoother for all of you. So let's look at the other side of the coin, though. How about improving ABA treatment outcomes as we address the medical comorbidities? Unfortunately, there's not a ton of stuff that's published on there. There was one study that came across my desk. A friend of mine sent it to me actually about a year ago on Bumex is the brand name. Bumetidine, I think is the more technical term. And it's the only study I could find that actually demonstrated that Bumex alone, ABA alone, were not as good as when you combine the two of them together, that you would actually have better learning outcomes as a result. I think that part of the problem here is there's a lack of day-to-day collaboration among the different specialties. In particular, I think there's a lack of collaboration in the sharing of that data. CARD built a software platform years ago to track treatment progress and the curriculum and the assessments that we do, and that's a wealth of behavioral data that I use frequently to do different studies or just to track audit quality of our patients' progress. And in it, we put places for a lot of the medical information to get stored too. But the problem is we don't have any doctors using it, and so the only source of data we have are from the caregivers to bring it. And if we get it, then awesome, we'll enter it in. But that really limits the degree to which I can approach this more scientifically and try to say, what's at play here and how are these two or 20 different procedures all working together. I think there's a lot to be gained from a bit more of a collaborative exchange. Honestly, that's one of the things I'm going home with as an action item, is try to reach autism EMR groups, CHARM being one of them, and get better integration. I went around though and asked a number of our senior clinicians. I was like, hey guys, I'm giving a talk on this stuff. What can you give me as far as graphs go that have some real good data? And so they passed me some graphs, and I went through them, and some of them I was like, I'm not seeing it. I don't see the response they anecdotally are telling me about. And so I kicked those aside. And I just chose a few that I thought would be good demonstrations of what happens when we can work together on this stuff. The first one I want to talk through is a guy I'll name Mathew. He came in a number of years ago with a diagnosis of autistic disorder. At intake, he was 3.5 years old. Deficits were no eye contact. Speech consisted of 5 one-word requests, tantrums, throwing himself on the floor and screaming, no interest in peers, and you could read the rest of it if you want. Treatment then lasted 1 year and 7 months. He got a high intensity of treatment during that period of time, 40 hours per week. At one point, he was moved onto the GFCF diet, Antifungal medications were used, diflucan and nystatin. And then at exit, he was roughly 5. He was in a typical preschool with an aide to help with some of those social interactions. He had developed quite a few skills and was doing pretty well. And just a heads up on all of these different graphs, I'm not claiming any particular medical intervention was the thing that worked or not. That's well outside of my area to even have an opinion. I'm just using these as examples of what we actually observed in these kids, though. So when he came in, started after only about a month, he was put onto a GFCF diet. At the start of treatment, his non-compliance was extremely high. That's that pink one, up above 300 occurrences in a month. The self-stimulatory behavior was also very high, and then tantrums were high, roughly over 100 a month. So once the GFCF diet was put in, we do see a decrease in the tantrums. Again, I'm not saying any particular thing was the cause there. It's often maybe all of it together. But he was also then put on diflucan. We see a decrease in some of the self-stimulatory visual behaviors, but then they kind of come back up again. He was put later on to nystatin, and then you see later on he was put on to probiotics. By the time he ended up ending treatment, the tantrums were pretty much at a 0 rate. And while the self-stimulatory behaviors were still, I would say, kind of higher than we would like to see, they definitely had gone down and stabilized in their presentation. And so this is another case, I call him Daniel. That's my son's name, actually. So diagnosis, though, was autistic disorder. He came in at age 2. His deficits were receptive vocabulary. He had 10 words, expressively 3 words. He could say juice, open, and ball. He had no eye contact, severe tantrums, crying, aggression, elopement, self-stimulatory behaviors, including gazing, mouthing objects, and toe walking. He was in treatment for almost 2 years, 1 year, 10 months. He averaged 30 hours intensity each week. And what was interesting here is that at one point he was moved onto a specific carbohydrate diet. He exited at age 5. He was in a typical preschool with an aide. He had mastered quite a few skills during that period of time. And I'll just show you the graph instead. So what we see here on new skills mastered per month. So at start, I guess he was on ABA plus IgG, allergy elimination diet, Feingold diet, rotation diet. And we see an increase in those skills per month. He was then moved to the specific carbohydrate diet, and we see a lot of skills being mastered each month. To be honest, I don't really find this graph super compelling in the presentation on it. It seems to be just a nice, steady state of things being mastered. We start to see a little difference though here when we're looking at the challenging behaviors. These are all the self-stimulatory stereotypical behaviors. And so, again, it's not a kind of a night and day change, but we do see a nice steady decline in all of the self-stimulatory behaviors. Now, the one graph though that made me say, hey, I really want to show this this case though was this one. When we look at what happened to his aggressive behavior. So at the start of treatment, he was about 50 to 60 occurrences of aggression each month. When he was moved onto this diet, we see a pretty much immediate drop and the aggression not returning at all. And so this is, I thought was pretty interesting and it was exciting to be able to show. So I'll talk now about a slightly different client, Emma. She came in with Asperger's disorder. Her age was 3.5 when she started. The deficits were poor eye contact, extensive vocabulary, but she didn't use them properly with peers. Lots of ritualistic behavior, really no theory of mind. Her treatment was fairly short. It was 10 months and on the lower end of intensity with 10 hours a week. She was put on Lexapro and Pro-DHA and Core Omega. At exit, she was 4 years old, a little over 4. She was in a typical kindergarten with no aid, and she could initiate conversations with peers. She had a number of friends, and so on. And so when we look at her graph, we see a nice steady decline across all of these different conditions. ABA alone, we see a decrease with the non-compliance. I think is pretty significant, and a pretty significant drop in tantrums and ritual stereotypies right in the first couple months. But things continued to progress and get better as she was moved to Lexapro and then further on with Pro-DHA and 4-Omega. This wasn't the graph, though, that I was really excited about. The one that I thought mattered the most was actually looking at her skills that were being mastered per month. We see an okay amount of mastery occurring in the first few months of treatment when it was ABA alone. Lexapro didn't really seem to have any significant increase in what she was learning per month, but we do see a pretty dramatic increase in the new skills being mastered each month once she was moved to the Pro-DHA and 4-Omega. This is an 18-year-old guy that we've been treating, actually, I believe, for about 16 years. He had regressive onset when he was 18 months of age. A lot of medical issues his whole life. Seizures, I believe, started when he was 7. Self-injurious behavior started to emerge quite strongly around 12. And what we observed here, though, he was put on Prilosec right here at the start of this graph. And you really see there's not a big change in the rate of self-injury and the tantruming, which is what this line is really representing. So he was engaging in self-injury about once every other hour, and that's pretty consistent all the way through until last June when he was put on taking antacids, when he was noticed to be getting agitated or following a meal. And then he was put onto, in mid-July, he was put onto a low acidic diet. And I thought that was pretty remarkable in that, we see a really stable, relatively high rate of self-injury occurring for the past year, but then moving, just addressing the acidic nature of his diet and what's had going on. Since then, we've only seen 2 days where he engaged in self-injury since then. So, maybe it doesn't require, really a lot of fancy stuff. He's taking Tums, and that seems to be helping quite a bit. What can we actually learn from these? One is, the point wasn't to say, hey, this is the type of treatments that are going to work with your kids or with your patients. The point is to show that we can, once one thing gets addressed, once a medical comorbidity gets addressed and under control, we can then go and make a lot more gains on the behavioral front as well. And so the message I would say, kind of a take-home point is include your ABA team in the medical care. Ask for the data to be shared. Ask for them to work alongside each other. If you don't have that from your ABA team, if they, because unfortunately, a lot of the training programs teach them to put on blinders and just ignore everything outside of what is behavior, and we like to say, well, it's all behavior, and well, yeah, it's all behavior, but what drives that behavior is 1,000 different things. And so I think we can accomplish a lot more when you get them integrated. I always love it when I have parents actually show up with that notebook, the binder full of all of the medical history and all that they've tried, because then I can put together a more complete picture of what actually has been working or isn't working. When I was at the Kennedy Krieger Institute, I saw a fantastic example of what kind of gains you can make in treatment when there's an interdisciplinary approach, when you have all of the different experts bringing what they know. And before that, I worked at a developmental center for adults with severe intellectual disabilities, and I saw the opposite. It was a bunch of infighting because the specialties just didn't respect or care about each other's opinions, and the people who then suffer are the patients, because if it's about your egos and all that. So look, if you're a parent and you have the kid, make sure that your teams don't have the egos, that they're willing to work and they understand that the point is to try to get your kid better. And if we're the clinicians in the room, we need to talk. We need to have more conferences like this to actually build off of and start to integrate what we're doing together. And I'll end there. Thank you.